aortic rupture, it's based, as it says by the name, it's trauma or due to deceleration injury, most commonly at the aortic isthmus, and that is proximal descending aorta, just distal to the origin of left subclavian artery. The X-ray may reveal widened mediastinum. So if we take a look at this image, it's not related basically, but it's just to know where the isthmus is. So basically, this is the aortic isthmus, so it's this part. It doesn't have to be stenosed over here, but this is the part of the aorta that is called the isthmus. And as it says, is just distal to the origin of left subclavian artery. So we have to take, okay. So we have this is the left subclavian artery, and this dotted line is the left vertebral artery. So basically, the isthmus should be here. This is the aortic isthmus. Okay. So now for the aortic dissection, it is a longitudinal, well, that needs to be known, that it's longitudinal. It's not like cyst formation, basically. It's just longitudinal intimal tear forming a false lumen. So there is like a new false lumen that should not exist is being created within the wall of the aorta. It is associated with hypertension, bicuspid aortic valve, which we said it should be tricuspid, inherited connective tissue disorders like Marfan syndrome can be present with tearing, because basically the disease is tearing the aorta wall into two pieces in order to create that lumen. So if it's just, this is the normal wall, then in this case it's just something from within is tearing. There you go. So this lumen is false lumen. That's why you feel the tearing sensation, and it is sudden onset chest pain, and it's radiating to the back. Okay, so it does go to the back as well. Plus minus markedly unequal blood pressure in arms. So very noticeable pressure difference in both arms. The chest X-ray can show mediastinal widening, can result in organ ischemia, of course, because we're just disrupting the structure of the aorta, so it may end up with ischemia to the organs. And also there is a risk of aortic rupture and death. So we have two main, we have the Stanford classification. It has the proximal type, and the Stanford type B, that is the distal. So there's type A and there's type B, but they're both called Stanford classification. Well, we do have some other classification that is here in the image called DeBakey classification. So but basically what we're talking about the Stanford classification. So for the type A, it's the proximal. So it involves the ascending aorta. So red arrow in A. So this is A. And if we think about it, this image is kind of cross section, because this is the vertebra and this is the aorta, and this, as we can tell here, is the area where we are having the aortic dissection. So this is the area of the wall rupturing. So and this is of course a cross-sectional. So if we imagine how this image was taken, is basically there was a cross-section over here probably, or in here. The important stuff is that it's a cross-sectional image. So it involves the ascending aorta, may extend to the aortic arch or descending aorta. That is the blue arrow. So this is type A, this is the ascending aorta, while the blue arrow over here is the descending aorta. Okay, so it could involve the ascending or descending aorta, but probably they should just be start proximally to the start of the aorta coming out of the heart. So it may result in acute aortic regurgitation or cardiac tamponade. Treatment is, of course, surgery. So this is type A. It could involve only the ascending aorta, as in here, or the whole thing, but starting from the beginning of the aorta. So for the Stanford type B, it involves only descending aorta. So it should not involve the ascending aorta at all. It should not involve this part at all. That's why it's, there you go. This is type B. It's just, this is the descending aorta. So below left subclavian artery. Yes, of course, the descending aorta starts below the left subclavian artery. This is the left subclavian artery. So it starts below the left subclavian artery. The treatments are beta blockers, then vasodilators. So we start with beta blockers, then we use the vasodilators. So yeah, that's it for aortic dissection. For the subclavian steal syndrome, it's kind of an easy concept actually. So what is happening is that there is stenosis of the subclavian artery, okay? That's one. Where is that stenosis happening? It's proximal to the origin of the vertebral artery, okay? So this is the area of stenosis, and it says right here, proximal left subclavian artery stenosis. What we have here, this is the left vertebral artery, so this whole artery is the left vertebral artery, okay? So what it says that there's hypoperfusion distal to the stenosis, so there should be reverse blood flow in ipsilateral vertebral artery, leading to reduced cerebral perfusion on exertion, of course, of the affected arm. So what is happening here is that due to this stenosis over here in the subclavian artery, the blood coming out of the aorta going into the upper arm, this goes into the left arm, so is not going or not flowing normally as it should, because it's already stenosed, so it cannot just go freely. So that means because of this stenosis, the arrow doesn't go really nicely over here, so it's just reduced blood flow to the left arm. So that means the on exertion, on whenever we need using the left arm or something, the left arm is still needs some blood, like it needs to be supplied by blood and oxygen. So what happens here is that the vertebral artery, left vertebral artery, goes into the rescue. The vertebral artery should normally end up at the skull and feeding the brain, a part of the brain. So after multiple connections, of course, but I mean, ends up in the brain finally, supplying the brain. But whenever he sees, and the blood flow should normally in the vertebral artery go this way. So it's from the aorta to the brain. But in our case, because we have a stenosis here and we have reduced left arm blood supply, the vertebral artery would go the other way. So it should start now moving the blood, the flow goes in the wrong direction. And that is in order just to solve the problem and help supplying the left arm. So what is happening, that's why it's called subclavian steal, because the subclavian, because of its stenosis over here, is stealing the normal blood that should just go up into the vertebral artery and feed the brain. But what is happening is that it's stealing its blood supply and moving it to the left arm. So that's why the subclavian is stealing from the left vertebral artery. So this causes arm ischemia and pain and paresthesia. Of course, these are some signs of reduced blood supply to the arm, with vertebral basilar insufficiency, like dizziness and vertigo. These are related to the base of the brain. These are finally related to the base of the brain, and they happen because the vertebral artery is to the brain now is reduced, because we're taking the blood that should just all of it flow to the brain. Now we're moving it the wrong way. We're moving it to the left arm. So There is more than 15 millimeter mercury difference in systolic blood pressure, in the systolic blood pressure between the two arms, like the left arm and the right arm. It is associated with arteriosclerosis. It's okay, associated with arteriosclerosis, Takao-Su, arteritis, and heart surgery. And that should be it. Okay, so what we have here is that there's an image of the aortic dissection. Okay. The blood should flow normally this way, but because of turbulence flow and whatever causes, that would cause an intimal tear over here, and then the blood would go abnormally in this opening, and that is all of this blue thing is abnormal because it should not exist. It should be only just a normal wall, but due to this opening, it's going the wrong way. And then if it ruptures to the outside, then that's called bleeds into the media intima. Mediastinum, ouch. If the whole wall ruptures, as we said, aortic rupture, then this would bleed into the mediastinum, of course. But if it stays around the heart, like in this case, that's how it's causing cardiac tamponade, because it's pressuring the heart.